So I think, of course, lymphoma here is on the cutting edge of where this whole field is going. I've been working on immunotherapy my whole professional life, and it's really exciting to see immunotherapy approaches becoming more and more successful. I think the success of CAR T cells has shown us how powerful patients' own immune systems can be to fight the cancers. I also think it's very exciting for patients to believe that their own cells are the ones doing the fighting rather than some horrible poison that a doctor's putting into them. So I think that this is the tip of the iceberg of where we are going in terms of looking to exploit patients' own immune systems to be able to do this. Now, if we can have immunotherapies in general replace salvage therapies, replace autologous, replace allogeneic stem cell transplant, that's a huge advance. The current licensing indication for CAR T cells is for patients who've got relapsed or refractory diffuse large B-cell or mediastinal large cell lymphoma, who have either relapsed after a prior autologous transplant or who are not candidates for transplant in terms of not being fit to get to transplant or in terms of not responding well enough to salvage therapy. The first is the expectation of what can the CAR T cell achieve. The results are very encouraging, but this is a very expensive technology that does not guarantee the outcome. It's certainly a better outcome than can be achieved without it. In terms of what people have to understand going in are the rather acute toxicities. Now, almost all of the toxicities of the CAR T cells occur quite short after the time of infusion. Patients have to understand that you need to collect the cells and they need to be sent off to be processed, and there's a period of time when those cells are off that we have to try to keep the disease under control. Now, all the members of the Lymphoma Coalition will know very well that if you have relapsed and refractory diffuse large B-cell lymphoma that is difficult to control, holding it in control for a month while those cells are being made can be a challenge. So we might not necessarily be able to get all the patients we want to into that setting. The second one is the period of receiving some chemotherapy, what we call conditioning, to allow the CAR T cells to come in to the patient and then be able to expand. So there's chemotherapy involved in that. And then there are two rather unique toxicities that occur with CAR T cells that patients have to be aware of. The first, many lymphoma patients will be quite aware of the concept. That's what we call cytokine release syndrome. And I say why so many lymphoma patients will be aware of it is that many patients with lymphoma, of course, have had antibodies and have had a reaction to the antibody. And the antibody reaction is part of what we call a cytokine release syndrome. Those shakes and chills and having fevers. Now, the cytokine release syndrome that can occur with CAR T cells is kind of like that, but much more severe, with very high spiking fevers. Now, we've got a very good understanding of what causes that and how we can manage it and how we come in with things. In the very early days of the trial development, people didn't know whether we should be trying to stop it and whether we needed it to have the T cells expand. We now know how to intervene. The second and probably more disturbing side effect is this neurological toxicity that occurs. Patients become very confused, often somnolent, sometimes to the point of requiring intubation in intensive care units. It happens a little bit later than the cytokine release syndrome, usually happening about a week to 10 days after the infusion of the cells. It's a little bit different with each of the different products that are available, but it's a toxicity that people have to be very well aware of. The good news is for the patients is patients almost never remember that it happened, but it's very disturbing for the families to see their loved ones becoming so confused and so disorientated. Once that toxicity is over, the two things we have to consider then are, is the disease going to come back? And the good news at the moment is that if we can get people out to a year and not see evidence of the disease recurrence, we're seeing very, very good outcomes in those patients. And the second one is that, of course, the CAR T cells at the moment target the lymphoma cells, but also target the normal cells. And there is, in some patients, this hypogammaglobulinemia long term. Now, of course, some people going on to IVIG replacement therapy, but of course, replacing immunoglobulins isn't the same as having your own immune system. When I would potentially not offer a patient a CAR T cell is if you really cannot control their disease progression. Patients need to be off chemotherapy for a period of time for these cells to be able to expand. If you cannot get the patients off chemotherapy and the disease is progressing despite that, you might argue that's when they need the CAR T cells most, but it's also when they're just not going to work. The second thing also is, of course, is a patient fit to receive CAR T cells? Now, what we are seeing is that there are many patients who have not been fit to consider an autologous transplant, not been fit to receive salvage therapy, and some people in whom we would never have considered a transplant, that we used to say, would they tolerate CAR T cells? Our recent experience suggests that we're taking patients up, into their 80s through CAR T cells very successfully. So that's a little bit a shifting field. There's been a little bit nervousness about, how would people tolerate it, but as people gain more experience, as we've done in many other treatments in the past, the age limit's going up and up. There are all sorts of clinical trials whenever you've got a new therapy which looks effective to be trying to find out. That's when we're doing it now. When is the optimal time to be doing it? That's the question of clinical trials. And the big clinical trials that are going on right now are asking the question is, can CAR T cells replace autologous transplant? Or, is the place where we have them right now the right place to use this technology?